Hopefully you can see my slides. So this is a double act, myself and Hilary. I will start with a bit of a framing, and then Hilary will expand with some specific examples and then wrap up. So just to start with some definitions, I think is helpful because capacity development, capacity building are words that are used a lot. I think a general definition, this is from FCDO, activity which increases the ability of individuals and organizations operating within broader institutional framework to deliver specific tasks and mandates. So that's a very universal definition. And then the second definition comes from the UNDP primer, which really acknowledges the positionality of UN and international partners in capacity building. Capacity development is an internal process for which external actors play a supporting role. If something does not lead to change that is generated, guided, and sustained by those whom it is meant to benefit, then it cannot be said to have enhanced capacity. So I think it's really important to keep that in mind, that the capacity development is an internal process for which external actors, and we would count ourselves among those, as playing a supporting role. That's how we approach capacity development, and that's our ambition. An important idea, we have the UK-PHRST triple remit, but an important concept is the fact that this is integrated. So capacity development does not stand alone as a separate track or a separate initiative. It's integrated throughout research and response. And Hilary can give some more specific examples which we think illustrates this quite well. The fundamental belief and assumption behind this is that we believe that peer-to-peer technical collaboration in outbreak response can bring mutual benefits. And I say mutual with emphasis because we gain and learn a great deal from engagements with partners in outbreak response. So it's not a one-way street, it's very much mutual. So we are building our own capacity at the same time. And some of the ways that this happens, just a few examples would be sharing experience from our settings or from around the world, co-designing solutions to problems, co-producing knowledge through research, and also strengthening networks and institutions. You could add to that. And just a simple example on the research side. So a response to an outbreak inevitably leads to many, many questions. And so it's a collective effort to put those questions into research and put the results from that research into response. So thus we could see really response does not stand alone. Preparedness is in response. It should be a thread through the response activities. And just to build on that idea of preparedness and response, public health emergencies are in many senses disruptors. So they disrupt the system, which create actually opportunities for change and learning. And what we try to do is adapt our offer, our contribution to the phase of the emergency. So and also acknowledging the constraints. When I say acknowledging constraints, it's just to say that as a rapid response team, a rapid support team, we have to be sure to maintain a predictable level of capacity that can be drawn upon in an emergency. So there is a balancing act between the preparedness and the response. But it's important that response activity is used, and learning from response activity is used to lead into activities in transition and recovery phases, and again in preparedness phases. And so here's a kind of diagram to illustrate that kind of cascade, and it's a somewhat artificial construct, but in the response we would be participating in co-working, co-designing solutions, sharing examples, peer-to-peer learning, perhaps operational research. And then after action review, we would be, after the event or in the transition event, we would be keen to participate in after action review, implementation of recommendations and learning, more research, shared learning, the knowledge hub, which is a mechanism of sharing information, which we'll come to later. And again, this loops back into preparedness, training and education, participating in communities of practice. You could add research there too. And just to emphasize that we're about working with, not doing for. So I think this has been many times emphasized today. It's not a parallel system. We're working with you and our partners, and just to say, underlying that is ultimately is about mutual trust, respect, and understanding. And important just to point now, I think, to the context in which we work. So Ultimately, much of our work is pushing towards greater health security. That's the ambition. And we have our framework for that from the International Health Regulations, which set out how countries should seek to prevent, detect, and respond to hazards. And so I've just highlighted some of the key parts of the IHR evaluation framework. So we have the state party annual reporting, joint external evaluation, simulation exercises, and after action reviews, which obviously lead into the National Health Action Plans for Health Security, which is the sort of primary multi-year mechanism for planning and developing national capacity. And it's worth just emphasising again that we work and align with many, many different initiatives, UK, regional, and global. So we've heard from UK government departments and programmes, institutional health partnerships, so for example, Public Health England, through the International Association of National Public Health Institutes, IANFI, academic consortia, technical networks, communities of practice, and of course, national, regional, and global public health and academic institutions. So it's really a web. You can think of it like a human web. And also, just to emphasize, we have to put global health security in context. You can't separate global health security from health system strengthening and the universal health coverage agenda. So a functioning public health system is inherently dependent on a functioning health system, and vice versa. So I'll hand over to Hilary now to lead us into some specific examples, which we think can illustrate some of these ideas. Hilary, over to you.
Thanks, Ashley. So I'm going to take you from that big picture of global health security and health system strengthening, which is so crucial, but look down at some more granular examples. And I guess the first thing, although because we are all so aware of the pandemic or all involved, I will look at COVID-19, but I also would like to say that many of our work and our capacity development and all our work has been in other areas up until this year and continues to be. So when COVID-19 struck, in fact, our team was initially deployed to 2 areas. We went to Africa CDC in Addis to give some surge capacity. Whoever's got their microphone on, could you please switch it off? Thank you. So to give some surge capacity to the different pillars of the response there. And we were there face to face, then we came back, as Ashley said, to do remote working. Now, part of that remote working was actually developing alongside giving input and contribution to the policies and the strategies of how Africa CDC would support the member states in deciding how they were going to do their contact tracing, what was the science behind this, what was the best way to develop public health and social measures against COVID. So this was sort of, this was very much an illustration of what Ashley described as not a one-way street. I mean, we were learning, they were learning, we were putting our heads together to try and develop something, develop capacity in an area that, in fact, of course, was fairly new to us in this disease, but we brought our experience from other places. These webinars were in IPC and lab in risk management, and they were worked on together with the Africa CDC team and the National Public Health Institutes. Various people chipped into that. On a bigger scale, if you like, we ran a MOOC, a mass online open course on COVID-19 that, yes, it was led by the RST doing the nitty-gritty, but there were multiple actors, multiple speakers, people who came in and told us about their particular expertise. And in fact, 240,000 people took that course around the world over the 2 times that it ran. Just to give you an example, this is not the first time we've run a MOOC. We did one on outbreaks as well, with the same idea, identifying the questions that were priority through discussions with partners and networks, and then creating that MOOC. Also at an international level, we've been working very closely together on seroprevalence research. So you will know that there's much research going on into COVID-19. What we are not one area that is really unclear is the level of immunity or seroprevalence amongst the population, because so many people contract COVID-19 but have few or mild symptoms. And understanding that has really been a priority. I'll give you two examples. As I say, they're the African Union member states through the Africa CDC, which has been supporting member states to try and set up seroprevalence research. And we've also had a very close relationship in Bangladesh, particularly with the Rohingya populations in the east, where we are supporting WHO and the Bangladesh government to do seroprevalence there. That will be used as a model to then do seroprevalence elsewhere in the country. Looking at capacity development, alongside that, Cox's Bazar, we actually started, we were asked to go and deploy there, must be 2 or 3 years ago, for cholera. And I can hear a bell ringing, which means I'm going to have to speed up. And so we had lab quality experts there going to look at the quality of the way the lab was working for COVID, but also back then it was also about cholera and about diphtheria. Our lab scientists, our data scientists developed automated epi tools alongside the people working in the field there. And we had similar sort of situation in the Gambia with lab and with developing tools, but we also worked alongside the alert teams and the tracing teams to scale up that capacity. So I'll move, slide please, Ashley. Ashley?
Yep.
Thank you. Okay, so as I mentioned, there are multiple routes that we have employed for capacity development, both of our own, but also to support our team. And one I want to highlight here was actually at a really high technical level. So a colleague of ours went to Nigeria to work with Nigeria's CDC on monkeypox, and I think our colleague Kola has mentioned this. And through that development, through working on genetic sequencing for monkeypox, we heard last week that the team in Nigeria CDC had been able to sequence their own SARS-CoV-2 sequence from Nigeria. So this was a very quick, if you like, impact of capacity building. I mentioned before pre-positioned research protocols and team training in places like Sudan, for those of you who are here from my previous talk. So this is also building a research capacity. And we've done this, we're doing this in Uganda, where there's healthcare workers who are actually running their own research project with remote support from the rapid support team. And in Nigeria, I won't mention Lhasa again, because you'll all be fed up with Lhasa, but we're doing a lot of work in terms of remote supervision, remote support to teams that are running the research in the field. Just to mention then that there are peer networks. Our social science expert, Hannah Rohan, has worked with West African social scientists to build an epidemic response network that helps to counter misinformation, helps to try and spread the word around for behavioral messages and so on. And I mentioned before the Mental Health in Outbreaks Consortium. And then working together, I think you can see where we're going with this. When you're doing case investigation and mapping, you're sharing that expertise amongst people who have done it. Maybe there are better ways to do it, and so on. Same with Ebola, looking at the surveillance, the track and trace. So I'm going to, slide please, Ashley. Thank you. I'm just going to conclude with this to repeat the quote that Ashley put up at the beginning and highlight that capacity development leads to change that is generated, guided, and sustained by those whom it is meant to benefit, i.e. this is not something we sit around here in London or anywhere, even when we're deployed, thinking, oh, we'll just do a pop-up workshop. This really needs to be something that comes from the needs in the field to be able to make it useful. And I say future, I think we've done a bit of co-creation, Ashley's mentioned it, but really our future is to identify knowledge capacities together, to identify ways to share that knowledge and capacity, and identify key questions and methods to address them in all our 3 areas of interest: the capacity development, research, and response. And that's where we're going with our goals and aims, I think. Thank you, Alinda, and sorry for running over slightly.